Welcome to Critical Care Simplified. Today we're breaking down one of the most important foundations of ICU nursing, essential hemodynamics for new ICU nurses. If you are new to critical care, the monitor can feel like a wall of numbers: heart rate, blood pressure, MAP, CVP, oxygen saturation, urine output, cardiac output, and sometimes values from invasive lines or advanced devices. But every number tells part of the same story. Is this patient perfusing their vital organs? By the end of this video, you'll understand what hemodynamics means, how to interpret common ICU data, how to recognize early signs of instability, and how nurses help support patients through fluids, medications, and advanced interventions. Let's simplify it. Hemodynamics is the study of how blood moves through the circulatory system and the forces that influence that movement. In simple terms, it asks, how well is blood flowing, and is that flow delivering enough oxygen to the tissues? For ICU nurses, hemodynamics is not just theory. It is bedside decision-making. When a patient's pressure drops, their heart rate rises, their urine output decreases, or their skin becomes cool and mottled, those are not isolated findings. They may be signs that circulation is failing. The goal is not to memorize numbers in isolation. The goal is to connect the numbers to the patient in front of you. A patient can have a blood pressure that looks acceptable but still show signs of poor perfusion. Another patient may have a heart rate that is technically abnormal but stable for them because of their baseline condition. That is why trends, assessment findings, and clinical context matter. Hemodynamics helps you answer three major questions. Is the heart pumping effectively? Is there enough circulating volume? And are the blood vessels appropriately relaxed or constricted to maintain perfusion? Let's define several key terms you will hear frequently in the ICU. Cardiac output is the amount of blood the heart pumps in 1 minute. It reflects how well the heart is delivering blood to the body. Cardiac output depends on heart rate and stroke volume. Stroke volume is the amount of blood ejected from the ventricle with each beat. If stroke volume falls, cardiac output may fall unless the heart rate increases enough to compensate. Preload refers to the stretch of the ventricles before contraction. Clinically, we often think of preload as related to venous return and circulating volume. Too little preload can mean not enough volume returning to the heart. Too much preload can contribute to congestion and fluid overload. Afterload is the resistance the heart must overcome to pump blood forward. If afterload is very high, the heart has to work harder. If afterload is too low, as in distributive shock, blood pressure may fall because the vascular system is too dilated. Systemic vascular resistance, or SVR, describes the resistance in the systemic blood vessels. Increased SVR means the vessels are more constricted. Decreased SVR means the vessels are more relaxed or dilated. These concepts are connected. A change in one area often affects the others. For example, a septic patient may have low SVR because of vasodilation, a low MAP, and a compensatory high heart rate. A bleeding patient may have low preload because of volume loss, leading to decreased stroke volume and poor perfusion. In the ICU, the monitor gives you data. Your assessment gives that data meaning. Start with the basic values: heart rate, blood pressure, mean arterial pressure, oxygen saturation, respiratory status, mental status, skin signs, capillary refill, temperature, and urine output. Heart rate tells you how fast the heart is beating, but it does not tell you whether the heart is pumping effectively. Tachycardia may be compensation for fever, pain, hypovolemia, hypoxia, sepsis, anxiety, or decreased cardiac output. Bradycardia may be benign for some patients, but dangerous when it is associated with hypotension, altered mental status, or poor perfusion. Blood pressure gives you a snapshot of pressure in the arteries. But remember, pressure is not the same as flow. A patient can have a blood pressure that looks acceptable while still showing signs of inadequate oxygen delivery. Mean arterial pressure, or MAP, is especially important because it estimates average pressure driving blood through the organs. In many ICU situations, a MAP around 65 mm of mercury is a common target, but the exact goal depends on the patient, diagnosis, and provider orders. Urine output is one of the most practical indicators of perfusion. The kidneys need blood flow to make urine. A drop in urine output can be an early warning sign that the kidneys are not being perfused well. Central venous pressure, or CVP, may be used in some patients to estimate right-sided filling pressures. CVP should not be interpreted alone. It is most useful when considered with the patient's overall condition, trends, response to fluids, cardiac function, ventilator status, and physical assessment. When interpreting hemodynamic data, always ask, what is the trend? What changed? What else is happening? And does the patient look better, worse, or the same? New ICU nurses often encounter several types of monitoring. A non-invasive blood pressure cuff is common and useful, but it measures intermittently and can be affected by cuff size, patient movement, edema, or poor perfusion. An arterial line gives continuous blood pressure monitoring and allows frequent arterial blood sampling. It is especially helpful when a patient is unstable, on vasoactive medications, or requiring close titration of blood pressure support. Nursing responsibilities include leveling and zeroing the transducer, maintaining the pressure bag, checking waveform quality, assessing the insertion site, and monitoring the limb for perfusion. A central venous catheter may allow medication administration, blood draws, and sometimes CVP monitoring. Nurses monitor the line site, dressing integrity, infection risk, and any ordered pressure measurements. Some patients may have advanced cardiac output monitoring or pulmonary artery catheter data. These tools provide more detailed information, but the same principle applies. The number is only one piece of the full clinical picture. The safest approach is to combine monitor data with bedside assessment and communicate meaningful changes early. One of the most important roles of the ICU nurse is recognizing trouble before it becomes a crisis. Hemodynamic instability often begins with subtle changes. A patient may become more restless. Their heart rate may slowly climb. Their blood pressure may drift downward. Their urine output may fall. Their skin may become cool, pale, clammy, or mottled. Their mental status may change before the blood pressure looks dramatically abnormal. This is why establishing a baseline matters. What is normal for this patient? What were their values at the start of your shift? What has changed over the last hour? What changed after a medication, fluid bolus, procedure, position change, bleeding event, fever, or change in oxygenation? Look for patterns such as persistent hypotension, rising heart rate, narrowing pulse pressure, decreasing MAP, decreasing urine output, increasing lactate if available, altered mentation, weak pulses, delayed capillary refill, or worsening skin signs. Also watch for fluid overload, increasing oxygen needs, crackles, new edema, rising work of breathing, pulmonary edema, or worsening chest X-ray findings if reported. Early recognition allows early escalation. That may mean notifying the provider, checking orders, increasing monitoring frequency, verifying line accuracy, drawing ordered labs, preparing fluids or medications, or activating unit protocols. Hemodynamic support usually involves three major categories: fluids, medications, and sometimes mechanical support. Fluid resuscitation is used when a patient needs more circulating volume. Crystalloids such as normal saline or lactated ringers are common first-line fluids. Albumin or other colloids may be used in selected situations. The key nursing responsibility is to monitor response and safety. A patient who is responding to fluids may show improving blood pressure, improving MAP, better urine output, improved mentation, improved skin perfusion, or decreasing heart rate. But too much fluid can harm the patient. Watch for increasing oxygen needs, crackles, edema, rising CVP when monitored, and signs of pulmonary congestion. Vasopressors are medications that increase vascular tone and support blood pressure. Norepinephrine is commonly used in septic shock. Nurses monitor blood pressure targets, titrate according to orders and protocols, assess perfusion, protect for access, and watch carefully for extravasation. If a vasopressor infiltrates into surrounding tissue, this is urgent. Stop the infusion according to policy, notify the provider, follow the unit extravasation protocol, and monitor the site closely. Inotropes are medications that improve the strength of cardiac contraction. Dobutamine is one example. These may be used when the heart is not pumping effectively. Nurses monitor heart rhythm, blood pressure, perfusion, urine output, and patient response. Vasodilators may be used when reducing afterload or controlling blood pressure is needed. They require close monitoring because blood pressure can fall quickly. Sometimes fluids and medications are not enough. Mechanical circulatory support may be needed, such as an intra-aortic balloon pump, ventricular assist device, or ECMO. These therapies require specialized training and teamwork. ICU nurses monitor device function, alarms, insertion sites, perfusion, bleeding, anticoagulation concerns, and patient safety. When caring for a patient with hemodynamic concerns, organize your thinking. First, assess the patient, not just the monitor. Check mental status, airway and breathing, skin signs, pulses, capillary refill, urine output, pain, temperature, and overall appearance. Second, validate the data. Is the blood pressure cuff positioned correctly? Is the arterial line leveled and zeroed? Is the waveform dampened? Is the pulse ox reading reliable? Is the patient moving or shivering? Third, identify the trend. A single abnormal number matters, but repeated changes over time often tell the real story. Fourth, connect the finding to possible causes. Is the patient bleeding? Septic? Dehydrated? Oversedated? Having an arrhythmia? Experiencing myocardial dysfunction? Responding to a medication? Fifth, communicate clearly. Instead of saying, "The patient looks bad," give focused information. The MAP has decreased from 72 to 58 over 30 minutes, heart rate increased from 96 to 124, urine output was 10 milliliters this hour, and the patient is newly confused. That gives the team actionable information. Let's bring it together. Hemodynamics is about blood flow, pressure, volume, resistance, and perfusion. In the ICU, hemodynamic assessment helps you recognize whether organs are getting enough oxygen-rich blood. The most important concepts include cardiac output, stroke volume, preload, afterload, and systemic vascular resistance. Monitor values like heart rate, blood pressure, MAP, CVP, and urine output are useful, but they must be interpreted with the patient's full assessment and trends. Early signs of instability can be subtle: rising heart rate, dropping pressure, decreasing urine output, altered mentation, cool or mottled skin, weak pulses, and changes in perfusion. Interventions may include fluids, vasopressors, inotropes, vasodilators, and advanced mechanical support. Your role as the ICU nurse is to assess, validate, monitor, respond, communicate, and escalate. You do not have to master hemodynamics overnight. But every shift, every trend, and every patient assessment builds your critical care judgment. If this helped you feel more confident with ICU hemodynamics, like this video, subscribe to Critical Care Simplified, and share it with a new ICU nurse who is learning the same skills. Stay curious. Stay compassionate. Stay competent.